Morning, everyone. Today I am going to talk about circulation of CSF, cerebrospinal fluid. Visit me at www.painfreepartha.com and slides and around 300 to 400 slides are freely available, free downloadable and editable. Also my YouTube channel Pain Free Partha. Subscribe, watch and enjoy. What is the history about this circulation of CSF? There is a history about Hippocrates discussed water surrounding the brain and Galen referred to as experimental fluid. Emanuel Swedenborg said he is 1741 to 1744. See, what has happened is this fellow unpublished in his lifetime, but this manuscript was published in 1887. See here, 1741. People are worried about now publication delays. Magendie was the one who described the circulation of CSF. So you can just remember about Magendie and CSF circulation. What is CSF? CSF is a clear, colorless, transcellular body fluid within the meningeal tissue that surrounds the brain and the spinal cord and in the ventricles of the brain. It occupies the subarachnoid space and also inside the ventricular system. It is secreted by the ependymal cells of the choroid plexus and brain interstitial fluid, ependyma and capillaries also secrete. There is something called thylakoidoe of the third and fourth ventricles, which also contributes to the CSF. So what is the main thing? Ependymal cells of the choroid plexus. This is like this, arterial plexus. Now, how does it secreted? Now we know that it is secreted by the choroid plexus of the lateral ventricles, partly by the third and fourth ventricles, partly from the brain interstitial fluid. Now, how does it get secreted? Active and passive, both are there. Now it is a simple passive filtration of the plasma. Second step is an active transport from the interstitial compartment to the ventricular lumen across the choroidal epithelium. This involves carbonic anhydrase and membrane ion carrier proteins. It is not a simple passive ultrafiltrate of the plasma. It also secreted by the active transport mechanisms. Now I show here it is the lateral ventricles, third ventricle, cerebral aqueduct, fourth ventricle, cisterna magna, lumbar CSF, subarachnoid space. And it is moved by the venous and arterial flow. Now we can see again lateral ventricles, foramen of Monro, third ventricle, cerebral aqueduct, midbrain, fourth ventricles from here to the lateral and subarachnoid space. From here to the outer and inner. Yes, the same. It passes through the interventricular foramina to the third ventricle, cerebral aqueduct to the fourth ventricle. It passes from lateral and also the median and surrounds the spinal cord. CSF is present in the within the subarachnoid space, which covers the brain and spinal cord and stretches below and under the spinal cord to the sacrum. The spinal cord ends at L1 and CSF ends at sacral 2. This is very important. There is a connection from the subarachnoid space to the bony labyrinth of the inner ear and the perilymph in 93% of the people. So where is the extent? Brain, spinal cord, and along the spinal cord, more than the spinal cord. So spinal cord ends at L1 and CSF ends at S2. The volume is 150 ml and inside the ventricles, it is 25 ml and the rest 125 is spread between cerebral CSF and outer CSF and the spinal CSF. Older individuals may have volume approaching 350 ml due to cerebral atrophy. This is what sometimes we experience. We think that the old age will need only 2 ml of bupivacaine, 2.2 ml for hernia. But sometimes because of this, they may be needing little extra. So that is what is the decreased level in older individuals, even though they are more sensitive to local anesthetics. CSF moves in a single outward direction. From the ventricles, it moves down. But the flow is pulsatile, driven by the cardiac cycle and the pumping of walls of the arteries and the cilia and the ependymal cells. What are the three things which makes it circulate? Cardiac pump. Number two, the movements of the arterial wall, the cilia of the ependymal cells. These three make the CSF to circulate. Flow of CSF is driven by arterial pulsations, and they say it is reduced in hypertension. What is the volume difference in age? CSF volume is around 2 ml per kg for adult, 150 ml. But it is 4 ml per kg of children and 3 ml in children. Infants, it is 4 ml. Okay. That is why a high CS volume is there in infants. That is why we need a large dose. And larger CSF volume per weight makes it the headache very less. This is pediatric spinal anesthesia, is a different topic. CSF secretions may vary from 400 to 600 ml per day. Now you see, we have only 150 ml. 600 ml is secreting means 3 to 4 times the whole CSF is changed every day. Now 8 a.m. if we see the CSF, 8 plus 4, 4 p.m. it is not the CSF, it's completely different CSF. Because it is 150 ml and 500 ml is secreted per day. Now to remember, I say it is 150 ml volume and 150 mm water. It is not mercury. 150 mm water. If the cerebral perfusion pressure is less than 55, then the CSF production may decrease. And if the CPP is more than 70, CSF secretion is okay, even if ICP increases. This topic is about ICP, so I'm not going to detail of this. So 150 ml, 3 to 4 times a day, the total turnout happens at a pressure of 150 mm of water. Will it increase production after a prick? Spinal anesthesia does not lead much to an increase in production. Yes, there are certain temporary changes, but they are usually transient, and 1 or 2 hours it settles down. CSF is mainly water, 99%. So what is the CSF content? The remaining 1% protein, you see the difference here. Plasma protein is 6 to 8 and CSF is 15 to 20. Now chloride is high and glucose is around half to. That is why we need to take CSF glucose if we take biochemistry of CSF in meningitis. At the same time, we should take the blood sugar, because if the blood sugar is 250, it may be 125. If the blood sugar is 70, maybe 35 to 40. So we need to take a corresponding time blood sugar to have a say on what is the CSF value of blood sugar. Cell count is not there. Red blood cells is not there. So all these things makes a difference. Sodium is little high. Chloride is little high. Sodium is almost like chloride, you can see little high. This is the mixed thing. So there are certain things which are more results in dogs when we are extrapolating. Now the CSF pressure already we have told 150 millimeter of water. In lying down supine it is around the same. And sitting and standing may decrease slightly. That is why I am not very particular in putting sitting. Lateral decubitus it is same. Common position for lumbar puncture. CSF pressure may decrease after a CSF leak. It is dehydration, shock, hypovolemia. Post lumbar puncture, there is a temporary drop. Physiological pressure is increased intrathoracic pressure, Valsalva maneuver. Usually, sometimes they measure the labyrinthine pressure and extrapolate to CSF pressure. This lateral position 150, sometimes here if you flex the neck much, there is a jugular compression which may put it to 215 millimeters of water. Autonomic nervous system and CSF circulation. The choroid plexus relieve cholinergic, adrenergic, serotonin. The sympathetic nervous system reduces CSF secretion. Cholinergic system increases CSF. So these may be a circadian rhythm. Morning, this is more. Evening, this is more. That is because autonomic nervous system, sympathetic decrease CSF, parasympathetic, increase CSF. That is why the sodium content also makes a difference. Sodium concentration and migraine has been proposed, but this is not related to anesthesia. Increase in epidural pressure after significantly, yes, the dural sac compression. You can see in the scan, ultrasound, as soon as an epidural is injection, the dural sac is compressed, the CSF moves up. There is a pressure increase. That is what is called epidural volume extension technique to increase the spinal level. Now, this is what we have now told. Now, how does it drain? Very simple. CSF is produced from the blood and is returned to the blood. That's what it is. It is returned to the blood through arachnoid granulations. What are they? They are outpouchings of the arachnoid matter into the vein. Arachnoid matter is there, subarachnoid space is there. It is projecting into the sigmoid venous sinuses. This is what is called. From there, it drains into the veins. Now you can see this is the arachnoid villi and this is the sinus. And usually they have valves. They will not come back here. When the CSF pressure increases, arachnoid villi will develop here. Now you see, it's a normal CSF pressure, it's a high CSF pressure. See the arachnoid villi, the surface area is increased. CF has also been sent into lymphatic vessels near the cribriform fluid. It can also drain from here to here. So what are the functions of the CSF? It is coming from the blood, going back to the blood. Why should it be there? Okay. The buoyancy. Normal, our weight is 1.5 kilos. Brain, we don't feel it. There is no head weight. Here it has become 25 to 50 grams. That's the most important job. It floats. If the brain isn't floating, it is compressing, it will compress its blood supply. That's another problem if it is not buoyant. Protection of ischemia, jolted by hit, it acts as a shock absorber. And prevention of ischemia. Now this decreases. The prevention is aided by CSF pressure, limited space. That is a Monroe-Kelly doctrine. I will come back here. So buoyancy, protection, prevention of brain ischemia, homeostatic regulations. For example, too much glycine, it controls temperature and blood pressure. CSF keeps everything balanced in the brain. Important substances between brain cells. Clearing waste, that is what is called the lymphatic system, brain's lymphatic system. Metabolic waste go up. If they don't go up, they develop amyotrophic lateral sclerosis, something like that. So it clears waste. Now, what are the things? Number one, it is buoyancy. Number two, it is protection, shock absorber. Number three, it is prevention of ischemia. Number four is homeostatic regulation. Number five is clearing waste. The Monroe-Kelly doctrine states that the cranial cavity has a fixed volume. It has brain, blood, and CSF. Blood has got arterial and venous. Something increases, something has to decrease to maintain the normal intracranial pressure. That is called Monroe-Kelly doctrine. Failure means danger. 1 ml of CSF is pushed to spinal column with every systole and normalizes ICP. Now, during anesthesia, careful monitoring of ICP is crucial. Now, we are going slightly out of focus of circulation of CSF. This is all about ICPs. Effect of anesthetics. Some anesthetic agents can alter blood flow, volume, which can impact the components. Positioning, already I have told. Simple. Lateral position is okay, same. If we press the neck, the CSF pressure is increased. Fluid management also we have to. Now this is Monroe-Kelly doctrine. Now you can see normal brain, arterial volume, venous volume, CSF. Edematous brain, brain is edematous. Now CSF is decreased to maintain the arterial. This is compensated. Now if this is not compensated, now the increased ICP hydrocephalus will compress the brain artery, so becomes dangerous. Most important thing in anesthesia is see here normocapnia and hypercapnia. Blood, CSF, brain tissues. So the anatomy of circulation secretes from the choroid plexus of the lateral ventricles and also from the tila choroidae of the third and fourth ventricles and also from the brainstem interstitium. And this goes through the lateral ventricles, third ventricle, fourth ventricles, go laterally and also inside, circulates in the CSF and goes through the arachidoid villi to the sigmoid venous, comes back to the blood. Volume is 150 ml, secretion is around 5 ml, 3 times turnaround. And pressure is around 150 mm of water. What are the functions? Buoyancy, homeostatic, prevention, protection, anesthesia. And Monroe-Kelly doctrine is blood, CSF, brain, intranuclear cavity, same pressure. Something is altered, something has to change to maintain the pressure.